Okay. All right. Thank you for everyone who's joined us. I can see a couple of big groups there, so that's fantastic. And yeah, lovely to have people from Papua New Guinea, Fiji, and Solomon Islands, and maybe elsewhere. Like I just said before, if you want to put in the chat where you're joining us from today and who's behind your Zoom screen, that would be fantastic. Very lucky to have Dr. Natasha Layton here today to present a session on occupational therapy interventions. For I think all or most of you in the Pacific, occupational therapy is a profession that doesn't really exist in a lot of instances, and something that we get asked at Motivation Australia about a lot of the time, about occupational therapy. So this is just I guess a general session to talk about occupational therapy and some of the interventions that can be delivered through occupational therapy. And Natasha will do it a lot more justice than I'm giving it at the moment. So we'll get started. You probably go to the next slide. Yeah, thanks, Natasha. We first just like to acknowledge the traditional owners and custodians of the lands from which you're respectively joining us. For myself, based in Adelaide, this is the Kaurna people. For Natasha in Melbourne, this is the Bunurong people. We respect their spiritual relationship with the country that has developed over thousands of years and the cultural heritage and beliefs that remain important to Kaurna people today. And welcome to you all from right across the Pacific. I'll let Natasha introduce herself and start the presentation. Thank you, Natasha.
Thanks, Daniel, and Bula, everybody. It's wonderful to be here with you. We have not travelled much in the last few years, and so I feel I'm virtually with you, even though I'm sitting here in Melbourne and it's really quite cold. So my name is Natasha. I work for the RAIL Research Centre, Rehabilitation, Ageing and Independent Living Research Centre at Monash University, and I'm a volunteer with Motivation Australia. And my email address is there if anybody would like to email me. And I'm very interested in working with people who have different bodies and structures and functions, want to do diverse things with their lives. Occupational therapy is a profession that lets me stand with people, whoever they are and whatever they want to do. And I have a toolbox of interventions or things I can do that might enable people to do things for themselves that they value. And I hope by the end of this, you will have some clear and practical examples of that. So my specialization, often people have a general background. I imagine you all have background in some sort of training or experience, and then you become very interested in some things more than others. And the thing I am interested in is assistive products. So wheelchairs, prostheses, glasses, pickup sticks. There are many, many assistive products on the market and more are being made all the time. And I'm very interested in how assistive products can help and also how environments can help people to live the lives they would like to live. And this is a photograph of me learning about what good looks like. So what would it look like to have a good life, to do what you want? What do you need to be able to do what you want in life? And I'm learning from what I think of as expert assistive technology, AT, assistive products or assistive technology users in Kenya. And I would also like to share this slide with you because I've also learned some of the things I know from my colleagues in the Western Pacific. And this is a picture from the Pacific Rehabilitation and Mobility Conference 2019. And that was very interesting to me to see the practice and the excellent work happening in the Pacific. So today's purpose is to explain about occupational therapy, what we do, how we evaluate or decide what to do with an individual or with a community, more than just the one person, maybe the family or the neighborhood or the town or the city. At the end, for you to understand some of the strategies, some of the things occupational therapists do. And these might be useful because you do not have to be an occupational therapist to do these things. Many things I think you will do already that occupational therapists do, and there are some ideas you might be able to take to your practice. And we hope before the end that you can all tell me whether these things are of interest to you, how you could use them with your clients, and have a discussion. And I invite people to put comments in the chat box or to raise their hands, and Daniel will keep an eye on that for me, but I will also be stopping and asking you some questions, so be ready. So at the end, I hope you can understand what some of the strategies look like to do with different people, to understand about daily living problems and the different things you can do to help with those, and to think about what this would look like in the West from the Pacific Island perspective. So I'm going to start with 2 diagrams. This one is a little bit complicated. The next one is very complicated, and I hope nobody gets a terrible fright and leaves the webinar, because I will explain them. And diagrams can be useful to hold information, but they're only really useful if they have ideas to help guide us. And I will show you how this idea guides me. So people may be familiar with this diagram. It is from the World Health Organization International Classification of Functioning, Disability and Health. And I am in this diagram, Daniel is in this diagram, we are all in this diagram, the people we work with are in this diagram. And this diagram says that we may have a health condition, a disease or a disorder, or we may not. We certainly all have our body functions and body structures on the left. So this is our skeleton, our skin, our ability to think and be organized. We do activities in our life. I am sitting on a chair and concentrating on you. And we use these activities to do participation. So I am giving you a lecture and you are listening and maybe taking notes. And that is a participation in life based on the activities. If I could not sit on my chair, it would be very difficult to talk to you. If you could not see or hear me or get your system set up, you could not participate. So there are 2 levels, activity and participation. Daniel, can I just check if I'm waving my mouse around on the screen, but I don't think you can see it, can you? No,
I can see it actually, Natasha. Yeah.
You can. So I'm now pointing to the words contextual factors, which is made up of 2 things, the environment and personal factors. So our environments, as you know, and you know better than I probably, make a big difference to what somebody can do with their bodies and how they can participate. If it's not accessible, if there is no universal health care, if there is no money, these things are all part of our environment. Environment is also the attitudes around us. If when somebody goes in their wheelchair out of the house, everybody is frowning, this is not an easy environment to operate in. And personal factors, which is very important. This is are we a male or a female? Are we young or old? So it's our demographics, but it's also, are we resilient? Are we anxious? Have we got lots of education and experience? So you can imagine all these things make a big difference to how we manage these other things. So I've now put up a box explaining what occupational therapy does in these areas. We use strategies to change body functions and structures, and I will tell you what those are shortly. We try to address and to strengthen personal factors. If somebody is very anxious, we would work to make them less anxious. If they are someone with a lot of energy, we say, great, what is it you want to do in your life? So we work with these very positive or challenging things. We spend a lot of time modifying activities. So thinking, how can you do that? If you are someone with no arms and legs, how can you reach? You need to reach for something in your life. Are there other things we can do so that reaching, getting something can occur so that you can participate in being a student or being a mother? So we modify activities and we facilitate participation. And the last thing we try to do is turn environmental barriers into facilitators. And when I talk to my colleagues who are podiatrists or prosthetists or physiotherapists or nurses, they say this is a big different thing that occupational therapists do. You can probably all think of places where the environment is not helpful, but we get to work on the environment, not just on the person. So I have put a little picture there of my colleague, Deb, and you can see Deb is sitting in a wheelchair. So we know that Deb, her body structures and functions are affected by maybe a health condition, and she cannot stand, she needs this wheelchair. She looks as though she wants to, she's up and about, she's mobile in her wheelchair, and she has come to the beach. She cannot get to the beach. The participation would be going to the beach. She's mobile because she has managed to come to this place at the edge of the beach, but her wheelchair will not go on the sand. So one of the things we can do is say, how would this person, how would Deb how can we change the environment so that she can come onto the beach? Maybe we have to change the assistive product, have a wheelchair that is for the beach. In Australia and many places now, we have a track on the beach so that it makes a path for the wheelchair to go on. And I would also be saying to Deb, do you want to go to the beach? Is this important? From this photograph, she looks like she wants to go. How are you feeling about this? Is this making you very sad? What can we do? How important is this to you? As an example, the World Health Organization recently advertised for an occupational therapy consultant. And this is to go to the Ukraine to work in a spinal cord injury team. And I have just put here in blue to explain to you the sorts of things that people say occupational therapists do. So the first thing they want is that the occupational therapist would assess functioning. So how is someone managing with their body structures and functions, and that the occupational therapist would use tools that might be standardized or non-standardized. We do upper limb therapy, so treating the spinal cord injured body with physical techniques, mobilization, stretching, and so on. We might provide a splint to hold the body in a good position. And people who work in prosthetics and orthotics would be very familiar with, particularly with lower limb splinting. Occupational therapist tends to do upper limb splinting because it's about function and activity. We might adapt tasks, and I will talk more about that soon. So change the way people do things so they can still participate. We might modify the environment. We might do retraining in ADL. Do people know what ADL? Activities of daily living. Showering, dressing, eating, picking up, caring for somebody. And we might do prescribing assistive technology, seating assessment, wheelchairs, cushions, educating family members, and support of people to go home. If someone comes to the hospital and their home is not ready or able to fit them in their new different condition after a spinal cord injury, we might put in ramps or rails or make the doorways wider and these things. Do people have any questions at the moment? Has everybody survived looking at the ICF? Yes. Okay. This is my second and even more complicated diagram. Then I promise you no more diagrams. So this model is done by an occupational therapist called Roger Smith. And it's very useful, not just, I've told you how we look at someone and think what needs to change, their body, their approach and their confidence, the environment, or do they need to change what they do? This model helps me think from the beginning to the end, what is my treatment? How do I manage this person? What can I offer with my occupational therapy skills? So here we would take the example of Deb, and here is Deb. She is the person. She happens to be sitting in a wheelchair. And in her context, I look at her and I think, well, she's doing this task. She's trying to get to the beach. How she manages is affected by whether there is universal design and good access in the environment. And it's also affected by other things in the context. Is there anybody to help her? Is she welcome and safe if she goes to this place? So this is all my assessment. Then we might do a baseline measurement. So I would say, well, Deb, how far can you travel in your wheelchair? If the land is not even and level, if you are not on a concrete road, but if you are on sand, can you and the wheelchair manage this? So I would assess her function before I do anything, because then when I come to the end of my treatment, I can compare baseline and outcome and see what made a difference. Then we have a number of intervention approaches. And this probably would fit, I think, any of the work you are doing. I would welcome discussion of whether this sounds familiar or not, even though it's perhaps, I would not expect you to have seen this diagram before, which is from an American occupational therapist. But really, when somebody has a change in their body, there are only 6 things we can do. We can reduce the impairment, and I think lots of money and resources goes in healthcare to reducing the impairment. What about medicine? What about surgery or an operation? These are the medical treatments that might change. So that for Deb, that might be, well, what about if she has an operation so she does not have sore hips so she can stand and walk? So this is about removing disability. And occupational therapists don't work so much here. And I think when you look at the Rehabilitation 2030 guidelines from the World Health Organization, it would say we spend a lot of money on treatment and remediation. And actually, many people just live with these different variations in their body structures and functions. And it's perhaps a good idea to look at not taking those problems away, but making it easier to live with them. We can compensate for the impairment. So do things in a different way so it's not a problem. I could say to Deb, don't go to the beach, Deb. Go switch on your television and just look at the beach. Or look at some photographs of the beach. We have changed the activity so that it's not in front of her that she wants to go. You can probably think that would be a very different experience. Going to the beach and looking at a picture of the beach, very different. But there are things sometimes people choose to do that will just take away the need to do the difficult activity. We can introduce assistive technology products or devices and services. So that would be, for example, a beach wheelchair. We can redesign the activity. So it could be closer to home. It could be at a place where the water is very close to the path, so you don't have big problems on the sand. We can redesign the environment by putting a path on the beach or things like this. And we can use personal assistance. So if Deb has 4 helpers, she can be lifted to the beach. So there's lots of different ways to address this problem. And then, of course, I would measure an outcome in her function. I'm not going to suggest we worry about covariates. These are other things. If at the same time Deb has other treatment, then you think, well, was it the occupational therapy that made a difference? Might not matter as long as the person is able to do the thing they want to do. Are there any questions about that diagram? Just checking the chat box. Okay. I'm now going to give you a much easier way to think about all of that quite complicated material that we use to teach occupational therapy students. So I have said one thing about humans is their bodies, functions and structures, and we can reduce the impairment and compensate for the impairment at the body structure and function stage. Oops, I have said we can try and modify activities and facilitate participations. And what that means is redesigning those activities and introducing assistive products. We can turn environmental barriers into facilitators by redesigning the environment and using personal assistance. And we can strengthen personal factors. And what I've put there is working with people, not on them. And I'm sure the practitioners online today know about the idea in disability of working in a partnership instead of being a professional that makes a change to a person and they do not have choice about that. So I'm now going to give you lots of examples And we'll see if that makes sense. And then I would like to hear your examples. So taking an example of an activity, gardening. So I've explained one of the first things we can try and do is reduce the impairment. So if somebody wants to do gardening and they have very sore hands and wrists with arthritis, what can we do? We can rehabilitate hand function. And that might mean using heat, using gentle exercise, using mobilization to rehabilitate function of the hand. And I've got two examples of what occupational therapists do here that you could also think about doing. At the top is a diagram of different grips: the cylindrical grip, the spherical grip, the hook grip, the lateral grip or pinch, and precision tripod or pinch grips. So these are all different ways. Hello, my colleague, good friend, Alma Kwambu has joined online. I just saw her pop in. These are different ways that you can hold on to things. And if you are doing your garden and you have got very big problems with your hands, you can change the way you are gripping your tools. Sometimes that means making a bigger handle on the tool. Sometimes that means not using the tool so your wrist is bent, but in fact it's straight and you are using much more muscle strength. So you can make these changes to make the hand has less stress and less difficulties at joints. And the other picture on the screen here is splinting. So putting on either soft or firm splints for function to support sore joints. So those are some of the examples of rehabilitation of hand function that we would look at for a purpose, to get somebody able to go out and do some gardening. I talked about compensating for the impairment. So this is someone who their impairment is sore joints, maybe from arthritis. We can use joint protection and energy conservation techniques. And here is some pictures of people using two hands instead of one. In the example, it's pouring a hot drink, but I would be suggesting in a garden, use two hands instead of one to carry the heavy pot, to lift the plant, to manage the soil. Give yourself support and use the joints that are closer to the body to carry things. All of these things will protect the joints and conserve energy. Other energy conservation ideas that are really useful for anyone is to have a work rest routine. Do something, have a break. Do something, have a break, maybe 20 minutes on, 5 minutes off, or to change from a heavy activity to a light activity, and that will be less strain on the body. And I think probably people, you might find if you think you do this already yourselves or in your practice, that is called energy conservation techniques, which feeds into redesigning the activity. So work rest routines, use a clock, encourage people to mix things up. Think about whether it's easier to work in the morning or the evening or the afternoon, depending on energy and on inflammation. And staggering the tasks. Does it all need to be done on one day? We can introduce assistive products. And I'm sorry I've shown you a picture of, this is very much gardening in Australia, Daniel, isn't it? It's a lawn and somebody is, but anyway, this person is using a long-handled rake, but a handle has been put on that rake. So if you think back to what that means for the hands, instead of flexed wrists and having to grip onto the post of that rake, the person is able to add a power grip halfway down. So there are a number of ways to adapt gardening equipment. You can use, you can change the power ratio in some of the tools that are available using non-slip gloves, things like this. Using personal assistance may be perfectly reasonable. People with disabilities tell us it takes a lot of time often to do things, and it may take much longer than without the disability, and maybe there is a priority around which thing is important, which thing to spend time on it, which is why we would always say, what is your participation? Do you want to spend 90 minutes in the morning having a shower, getting dressed independently, or would you like some assistance with that so that you can spend that time and energy at your job or looking after your child? So directing others to do tasks is a very reasonable strategy to build in so that someone can do what they want in their life in a way that will not exhaust them over time. And the final idea, redesigning the environment. So lifting, in this picture, we have lifted up the garden bed so the person is not having to bend down. So of course, this will only work, this example, with a small plot where you have the infrastructure to do this, but the idea perhaps is one that is useful. Any comments or questions at this stage? Has anybody used any of these ideas? Somebody needs to be brave. Daniel, have you used these in your practice? Are you a podiatrist like Tom?
I'm a physio, Natasha, but and yeah, I have used similar type of strategies. And I'm sure many of our clinicians online will have as well.
We have modified spoons and forks for our spinal cases mostly.
Yep.
So we have done that, and the environmental changes that we mostly see is making of ramp for wheelchair accessibility.
Yep. Great examples. Yeah.
I can't remember. Yeah, we do so many things, but at the moment I can't seem to remember.
No, that's great. I can see Tao. There's one hand up there, Daniel.
Yeah, Sarah, did you have an example to give? Or Alma as well?
Yes. Hi, everyone. Hello.
Hi, Alma.
Hi. I from our end at NOPS in PNG, we've done modifications, and I guess I'll allow my colleagues on the other side. I'm actually in a different place at the moment, still in Port Moresby, but in another place. So Peter, if Lawrence is there, maybe he can share his experience of doing some modifications in a client's home back in Rabaul when he was working there. I hope Peter can hear me from his end. Did I lose you guys?
Okay. We can hear you fine, Alma. Oh yeah, I'm not sure if Peter can hear though. But yeah, thank you. We can hear you.
Okay. Anyway, if they are still discussing, I'll go ahead and share what we've done. So, sometimes we're challenged with clients, not being able to do the normal things. For example, taking a bath in the shower, and they need home modifications, and without that formal training or experience, we just try to help out, do those little modifications in their homes to still enable them to have that shower in the house and do the things that they want to do. So we've done that, but I guess it's not following procedures, the normal way of doing things.
Well, Alma, that's interesting. And I think this is why I said at the beginning, many of the things occupational therapists do, you don't have to be an occupational therapist to do these things. We are just a fortunate profession where we say, what will make a difference to this person? And then, so suddenly I can use a tape measure and I know to measure up a bathroom. But a builder can also do this. And if you
Yeah,
are working
yeah.
in NOPS with someone and you think this person needs to go in with their wheelchair, or they are not steady without their limb, with only one limb, then I think you have, everybody online has the skills to think, well, what needs to change? The environment probably needs to be flat. It's a problem if there are stairs, maybe to sit down, maybe to have something to hold on to. So I would really encourage people to think this is in your scope. You know, it's, and the main thing, the thing that worries me is when people think, oh, we do not have an occupational therapist, they cannot go home. Not, it's very important to think of different ways to do these things. And that, I think that is part of the learning series idea. Daniel, I can see Peter's team is there now, but also we have Rose and Sarah.
Yes, Rose here. I have an experience where we modified a folding bed using the plywood and screws, where we can fold the bed and take the client out to, because the client cannot sit for a long time. So we build a modified bed where we can take the bed out whenever the client wants to rest. The client is able to lie down and rest.
And so I love that story. So instead of saying we make this person sit up, you think, no, the body needs this resting position, but they need to participate and be in that different environment. And so you have used assistive products and probably some support to get from one place to another and made and delivered that for the person. Thank you. Did Peter want to say something in his team now, or Sarah? No, I think you probably think Alma has said it all.
I can see your mic.
Daniel, we have.
Oh, sorry.
Yeah, go on.
I can see your mic's off, Sarah, but we can't hear you, unfortunately.
How about now? Can you hear me?
Yes. Yes, we can.
Okay. Okay. I'd just like to share an example of how we modify activities here in the Solomons. I teach some our students on how to create some cardboard chairs. So this type of chair facilitates child with cerebral palsy to sit. And also, we also taught them how to create some pickup sticks. So out of just what we can find, the students can find, they created a pickup stick, and then they use them to help facilitate a patient with stroke to dress himself. So just by using a simple stick. So that's one way of how we've compensated and adapted the activities. Thank you.
Thank you. That's, these are exactly the very good things to be hearing. And we might get to talk a little bit later about sometimes there are safety issues with making things from nothing, or trying to bring in designs that are safe. But I think every occupational therapist would say to get somebody able to participate is essential to their quality of life. And so people must problem solve and think how to do that in environments with lower resources. I might go through some more examples now, and then we can hear from people again.
Yeah, I'm just sorry, Natasha, there's just some comments as well. So just to acknowledge the comments.
Oh, good.
Thank you, Elsie. Elsie's noted that
hello, Elsie.
A therapist needs to know what the client goal is when undertaking rehabilitation. So yeah, very good point, Elsie. Thank you. And then Elsie's also noted below that in Solomons in Honiara, they do home modifications, splinting using local resources like coconut shells. So great examples. Thanks, Elsie. And then in Gizo, in the Solomons as well, they also provide those strategies, providing rehab for hand for hand conditions, energy conservation techniques, advice on modification of environment as well. Thank you, Gizo.
Thanks, everybody. This is another example that my colleague Peter has let me share with you, and you can see Peter in this photograph. And again, this is a very Australian example, I think, but sometimes it's good to look at an example that is different from our usual practice to really think through what's happening here. So Peter is somebody who lives with polio, and people will be familiar with polio, and now he is getting older. So he was someone who walked for a long time, then he walked with calipers, and now you can see he is using a power wheelchair. And Peter, his goal is to do the washing at home because Peter cannot work, and Peter's wife goes to work now. And Peter looks after their daughter, and Peter does the cooking and the washing. And I wonder if you can see in these pictures and suggest to me some of the strategies that Peter has organised in his house. Can anyone see the hidden little piece of assistive product that is yellow in one of the pictures?
Pickup stick.
Pickup stick, that's right. He says it's the most valuable. Peter's wheelchair is worth a lot of money. He said, no, the pickup stick is his most valuable possession, because with this pickup stick, he is able to reach things he could not otherwise reach. What do you think about the way his washing machine and his dryer are organised from the point of view of his reach range? Do you think this is a barrier or a facilitator, something that helps him?
I think it is a facilitator.
Yep, that's right. He's still bending forward, isn't he? But from my occupational therapy point of view, I think if it's between his knee and his shoulder, then it's a sort of mid-range reach. So he's unlikely to have problems with his dynamic balance. And you can see him there able to reach into the machine. That's right. So often you would see a washing machine and a dryer on top of each other, but they're next to each other, and that makes life easier. He can also fold things on top of the washing machine. So we're not reducing the impairment for Peter. Compensating for the impairment, well, his environment design takes away the capability gap between the thing he wants to do and his abilities. He has redesigned the activity himself in a way, so Peter will do the washing and then have a rest before he hangs it out. Good thing it takes an hour to wash anyway. He has some assistive products. He does not need assistance, and for some people, they would not. I think if it was me, my passion is not to do washing. I would be very happy for someone else to do this, but for Peter, it's a pride that he doesn't want to use personal assistance. Yep. So thank you, Peter, for that example. This is now an example from Kenya, and this is a very different area of practice. So this is my colleague, Luke, and here there are many things an occupational therapist would like to do with this boy in Kenya, but sometimes some things are more of a priority than others. So you can see that Luke is doing a pressure ulcer dressing. That is not in the scope of practice for an occupational therapist in Australia. We don't know how to do this, but Luke is an American occupational therapist, and they have some different skills. I was very impressed with his skills. They do a lot with neonates, with tiny babies. But this is one of his skills, is dressing. So when the child has spina bifida and has an open wound, this is the biggest priority, of course, because if your body structure and function are not stable and well, it's very worrying. So the thing that Luke does in his practice is, first of all, immediately take care of the body and address the dressings. The next thing is to worry about the wheelchair, because these children are sleeping on mattresses that are made of plastic, And you can see the wheelchair there is foam with quite thick plastic on top. So this is a problem for a pressure injury. The material does not breathe. We would like to have material that is water resistant but vapor permeable, so it can breathe, and also to have some splits in the material and a thick foam. This is not ideal, but this is the reality of the resource setting for this child. So here in Luke's practice, in this example, he is trying to reduce we cannot reduce the impairment of spina bifida. He's trying to manage the body structure and function, look after the skin, compensate for the impairment, trying to teach a lot of compensatory strategies. So things like pressure lifts so that the child is able to manage his own pressure problems. Redesigning activities. When this child has this problem, he must change the way he does his transfers so that there is less shearing forces moving across. So that is part of the solution also. Introducing assistive products, the wheelchair. This wheelchair has a pommel. There's a lot of time spent with donors trying to get the correct wheelchair or the wheelchair that is not so bad. And again, this is part of the story, isn't it, of trying to work to a good outcome for people. Personal assistance, and then redesigning the environment. This is a very warm environment in Kenya, very moist, the air. And so there are limits to how much can be done to change the environment in the home where this boy lives. So that's an example. You can see how very different practice to someone who wants to do their washing, this little boy who wants to get up and go to school, but a different picture of what the occupational therapists do here. I have one more example from Kenya that I would like to show you, and then I would really welcome your opinion. So you just saw Luke working with one child, one individual, and I mentioned that occupational therapists also work with communities and environments. And at Bethany Kids, at this big children's hospital in Kenya, where children come when their families maybe cannot look after them in the village, and they come and they have go to school and they sleep at this place. And here are the toilets. So the picture at the top is an accessible toilet. So you could go in there in your wheelchair, you could wheel your wheelchair over the toilet. You might be able to do a sliding transfer onto the toilet because there's some room for the wheelchair beside it. There's a handrail. But this is very difficult for children with spina bifida because they do not have the temperature regulation, can't feel what's happening with when they are doing their washing. There's a particular routine with trying to have hygiene because children are not continent. They have urinary and fecal incontinence because the spinal cord has not finally closed. So it's like an incomplete spinal injury. So what Luke, the OT, did was work with the centre to build the seat that you see at the bottom. So the toilet, can you see the toilet is underneath quite a large sheet, and the sheet has got a hole cut in it. And so what the child does is back up in their wheelchair. So it's the right height for the wheelchair. This is all very low. It's for children. Backs up, and the child can transfer, do a sliding transfer and get their legs up onto that platform. So they are sitting over that toilet aperture. So their legs are supported, they're not dangling. The child is able to void because they are sitting over the toilet. And the other thing that is there is a hose and a tap, because children need to be able to wash very thoroughly, to do perineal hygiene, to wash and keep themselves very clean. One of the other problems that was happening was children were getting burnt because there was no tempering valve. The water was heated on the roof. It was solar panels, and very, very hot water or very, very cold water was coming. The children could not mix the water well, and they were getting some burns. So Luke worked to put in a tempering valve, which means that the temperature cannot be too high or too low. So when I met him, he said, I think I'm not an occupational therapist. I think I'm a plumber. because he is doing maintenance work around heating and building little seats in the toilet. But actually, by doing this practice, he has changed the environment for 300 children with spina bifida. So this was very important for him to work at the level with the people who maintain and build the centre to have a better environment for them. And I'm interested to know, when we were talking before and you said, Alma and others were talking about, you know, your treatments are in the hospital, but you can come to the home and maybe make some modifications so someone comes home. I wonder, is it easy to for your managers to understand that this is an important part of treatment and intervention? Can you imagine where occasions where maybe it would be good to change a big thing in the environment, but it's sometimes difficult, isn't it, when we're in a role as an individual therapist at a place? I'm interested in any thoughts on that. I did not ask a very clear question, Daniel. Can you help me rephrase my question?
I just think maybe to start off with, have many people done any redesigns in the home, or tried to redesign the activity or to compensate for the impairment in another way outside of the clinic setting?
It's a good question.
And then the follow-up to that is, if it's not being done at the moment, is that because there's an issue with an understanding at a senior executive level or a management level about the need to do home adjustments?
Okay. All right, I'll go first. So from P&G, because most of us, like in the management role, are clinicians, we understand that when a patient or client ask us to do, that's an area of need, and we need to address it. In situations where our managers further up, when we have to request for funding support to try and do the modifications, when they don't understand, and it makes it difficult for us. And so our clients, we have to discuss with our clients that there's going to be some cost involved, and if you can help us out to have those resources to make those modifications, and then we can carry out those modifications in their homes. So yeah, I think the benefit of being a clinician and then being a manager, it's beneficial, because then we understand in situations where a manager doesn't have that clinical background, then it makes it difficult to make those decisions quickly. And then having that understanding between ourselves as the service providers and the clients and their family members or carers.
Yep.
Okay,
Thanks,
I'll
Alma.
stop
That was
here.
a little bit. That's all right. That was a little bit broken up, but I understand you. So often the practitioner or clinician might know what to do. It's a manager who who can implement things and make the case to do your practice in a different place or a different way. And this comes down to, sometimes I feel when we are a therapist, occupational therapist, physiotherapist, technician, podiatrist, prosthetist, whatever, we stand with the client, but then we only have a limited, our work tells us you must do this, and we think we want to do this thing over here. So I think it's useful to come back to that WHO and say, no, it's important to work on the environment, because it's all about the person's goals. And I have just spent some time in Australia doing a study of how people get their assistive products funded. And we worked out the government have 88 different ways of providing money to people, and nobody understands it, not even the occupational therapist. So was I doing occupational therapy? Actually, I was looking at the services and the structures and the policies that affect how the people get the products. If that's the change I need to make, that's the change I need to make. I have another example of working in that I will share with you now, that comes from Argentina. So here, this is on behalf of my colleague Silvana, who's actually a posture and mobility specialist. So a mix of occupational therapist and physiotherapist, posture and mobility. She goes to this place to do wheelchair assessments and set people up with wheelchairs. And these people are very, very poor. And when she went to work there, she found she didn't need to be doing the wheelchairs. There were more problems than this. These children could not leave the village to go to the city. They needed to go to the city so the government would register them with a disability card. If they had the disability card, they had some money. They have funding for wheelchairs. But the government said, there are no children that need wheelchairs. None of them are registered with us. So Silvana had to work to discover that there was no wheelchair accessible transport to go to the city. You can see where people were living here. She was setting people up with adapted prams and things so that they could move around. They were on the dirt roads, and people lived in houses that you could not really easily modify this house. Silvana needed to make it so that people could live on the floor very easily, because if you put in a handrail, I think the house would fall over. So this is an example of where reducing the impairment was not the priority for these children. She wanted to redesign their activities so they could go to school. She wanted to introduce assistive products. They needed the wheelchairs. She had donated wheelchairs, but actually what she had to do was redesign the policy environment and explain to the government that there were people who had needs that were not met. Her strategy here was, she told the government, if you want to be in the newspaper with a good story, you can come and look at me organising the wheelchairs. And the government said, no, we don't go to those places. There are no pathways. You come to us. And Silvana said, no, we are too busy with the wheelchairs and the people to come to you. So the government actually sent a drone overhead to watch them do their clinic. And then the government did come. And now 4 times a year, somebody from the administration, from the government, comes to this place, to Salta, and registers the new children who need disability support. So this is a story about how someone who does posture and seating needed to work in a very different way to change the environment. That meant that now the children have the money, and with that money, the children together and their families are making a change to the community centre, so everybody can go and do dancing. So it's like a collective or a community environment change.
Yeah, on reflection, Natasha, as well, I asked the question earlier about home modifications and redesigning the home environment, but a lot of the clinicians here will be physios or prosthetists, orthotists who will have only worked in that way before in the clinic, providing assistive products or providing a rehabilitation service. I know that Elwyn is on the call, who's a leader of a community-based rehabilitation service in Solomon Islands. So they may have done more things in the community and in the home. And then also Alma and her NOPS team run an outreach service that would involve more work in the home and community. But certainly, yeah, it's great to hear about these things and adapting the roles of the different professions in each country to adapt to what's needed in the home and the community, certainly.
Thanks, Daniel. What I learned in Australia is that people have different jobs to do, and often it would be a social worker who looks after policy or finance. But I think when you look at the majority world, you just need to do the thing that needs to be done to make a change. And there are ways of skilling each other up, aren't there, to do this? So the WHO have the TAP for training in assistive products, and there are other sort of strategies, rehabilitation strategies, community-based rehabilitation strategies that that can mean it's that we can do what needs to be done. And I would also make the comment, and I think my colleague Peter, who you saw before in the slide, in Australia, where it's very rigid, oh, you have a problem with your leg, the physio will come. And now if it's a problem with the home, the occupational therapist will come. And now if it's a problem with your funding, the social worker will come. 3 people. Really, it's good if people have lots of strategies or interventions in their scope. So I just have a few more slides that now talk on a more general level about how we can learn these different strategies and interventions. Are people happy for me to move on to those and then we have a discussion? Yeah. Okay. So there are assistive technology organisations around the world. I have put up here ARATA, the Australian Rehabilitation and Assistive Technology Association. I'm very excited that PRATA, P-R-A-T-A, Pacific Rehabilitation and AT Association, we think is forming, Alma. And then there is Taiwan, Korea, Japan, Europe, ISPO, people are very familiar, I think, with International Society of Prosthetics and Orthotics probably, and Argentina, which is where that other story came from, and North America. And there is now a global organization which brings all these groups together, and we hope that the Pacific will become part of this group as well, called GATO, Global Alliance of Assistive Technology Organizations. And some of the people who I can see on the line today were wonderful volunteers taking part last year in our Western Pacific consultation, where we asked what matters in measuring assistive technology outcomes and impacts. And we heard from a lot of people. And we had about 300 people across the world tell us what was important. And then we had so much information and we had to bring it to make it very manageable. And then we asked the global organizations, we said, this is what everybody is saying is difficult in assistive products, getting assistive products. And those global organizations like the World Health Organization helped us to bring it down to 6 things that we feel need to change. Firstly, in the middle here is sharing data. So sometimes I think everybody on this phone call, on this webinar, would have good evidence of where somebody had a need at baseline before they had any treatment. You do an intervention and then their lives are different and better. So this data is very important to tell governments that we need to fund you, the practitioners, and also any of those interventions or supports that make a difference. And if we can share this data, and if we can use the same ways to measure things, that would be excellent. Silvana, my colleague in Argentina, says there are 3 different words in Spanish for assistive product. So when you look at the research, it does not look like a big story about assistive products. It looks like lots of small stories about different things. And in the Blue Pacific, we have many language groups as well, of course. So one thing is whether we can all share our data using the same language. It would be good to measure need. And I'm hearing some stories online about where as in Argentina, they did not even know there was a need in that community. So that's very important for us as practitioners, even if we cannot fix this need, to explain and identify it, because then that's the first step to making a change. We need to be able to write down and have time to do outcomes research. So just to say, well, when we have our person through NOPS or our person on a spinal unit, we don't just treat them in the hospital. Outreach is important. We must do some work with them at home, and we document what goes in to make that outcome good for the person, measuring the outcomes, and then the impact on the community. Has this changed things for the family? Has it meant the person can work, and so there is now more money for their children? So that's not just an impact on the person, that's a change in the community. And around the outside, to inform policy so that we get better policy, so that we are employed where we need to be employed. Do people have comments or questions about that? Daniel, I'm just checking we haven't for another 20 minutes. Am I correct?
Yeah.
Thank you. Does anybody feel they have time to write down, to document the work that you are doing, and to maybe to publish this? Does anybody have any time in their day for things like this? I'm thinking I did not when I was working in a clinic.
Natasha, sorry, did you mean the work you do with modifications and stuff? Did you mean that,
or any of the work that is important to you? So you probably make notes for your patients in the central record. Yep. So the question is, if I came to you and said, Alma, you have seen 300 people last year, what were the outcomes? How many people managed to go home? How many people could work? Is it easy to find that information or not easy?
Well, I guess from our end, it's not going to be easy for us to give that information, and that's because of the challenges that we have in terms of having a proper central database system to enter all those data and bring them together, collate it, and then analyze the data. Yeah, that's challenging for us. If I was going to report on 300 people, I know that I cannot do that. And when there's services like in PNG, we have 8 sites. So then trying to bring all those in, it's challenging for us. But yeah, we're working on another activity on that, trying to get a central system in place for data, especially for data for notes, so that we can have those information. But yeah, we do small notes, but we have to report 300 people. I know we won't be able to do that.
No.
And I know my colleagues will agree on that as well. Peter and everyone at the clinic, yeah.
That's right. But obviously you have done very good treatment with 300 people, probably. And lots of skilled work. So it's interesting to think about why is it difficult to get this data? Maybe for us in Australia, we tried it one time. When people come to us, we immediately think about the ICF and think, where will we make a change? What treatment will we do? Tick, tick, tick. We did not have time to look at the environment. We did not have time to ask them about. So sometimes you can do almost an audit or a list, and then you say after 1 month, oh, our practice is all, like my friend Luke, his practice was all about just the pressure wound. He could not get to the other work because he does this. So sometimes I think we need to do it in a way that does not give you extra work. But you are doing this work anyway. So if we can record it in a different way, then it tells, then we can use it to ask for more resources. So that's a big story of policy change, and that's quite tricky. And I think it's wonderful. What I hear is that the clinicians and the managers are very informed in this group. So you can say to your hospital management, you know what your practitioners are doing. Okay, so that is a big vision for how we can make some changes together. And that is also recorded in the global report on assistive technology. And many of you will have seen this diagram, which says we have people, our products, our personnel, and we are all the personnel, ways to provide things, policy that can be helpful or not helpful, all within rights. And so the global report is a very useful thing. For me, I can go to my manager and say, the global report says it's very important to put the user first. So don't just tell me to do hand therapy. I look to ask what the person wants first. Daniel, that brings us to our final slide here. And we've had some conversation as we've gone along. So I'm going to stop talking, and I'm very happy to answer any questions, or if people would like to think of a person they see or a treatment they do and talk about the ICF a little bit more or strategies, I'm happy to do that.
Thanks, Natasha. Just while people have a little bit of time to think, I'll also send out a feedback form. So everyone, if anyone has any questions that they think of after the session, you'll be able to write them on the feedback form, and I'll send that on to Natasha, and we'll just collate any of the questions and provide everyone with the answers to the questions as well.
And I would very much like to know, if Motivation Australia invite me back one day and we do this again, is it useful to have big and difficult diagrams, or is it best just to say, well, let us talk about some treatments? So I'm very happy to have feedback on that, because I love diagrams, but not everybody does. But I think people are familiar with the WHO. I could see in the comments from Peter there, we do a functional WHO work with patients. Would people like me to go back to that WHO diagram and just have a look at that? Not sure if I can do it without making people very dizzy. Yeah. Oh, Debbie says yes, please. There we are. The thing I love about this is it doesn't say that a person is a disabled person. It says we all have different things going on. While we have this here, an interesting idea for occupational therapists, and not everybody agrees with this yet, is this idea of the personal factors. Daniel, I don't know if you have any examples as a physio of where you can even have two people with the same condition, an amputation or a spinal injury or a disease, or if they are a parent of a child with a disability, you can have two people with the same thing, but one will cope very well and one will not cope well at all. And so sometimes that changes our treatment approach, doesn't it?
Yeah, certainly. And yeah, I would say that applies for absolutely everyone almost. Obviously, no one will ever have the same position or condition as another person. But even if they are very similar, as all the clinicians here will know, people will have very different responses and yeah, different coping mechanisms and perhaps be coping better than others. So yeah, that's why it's important, I think, as Elsie noted earlier, to have that, to take into consideration not only the individual goals, but the person's individual context and to modify their treatment and modify your response to that.
And I think it might have been Elsie who mentioned, yeah, a holistic approach. So yeah, just looking at the whole person. And I've certainly been sometimes working where I've had to work with the parent. I want to work with the child with the disability, but nothing will change unless the parent is in a different way of thinking. Do people find that they have to do a lot of work with families and family members? And is there time to do this work in your practice? I wonder if family often bring people. In community, you would be seeing the family at home, but in the hospital, I wonder if the families are present.
I think we have Giza, we can hear you, I think. You had something to say?
Yeah, I think family is important during, like, from my experience, training patient for day training. What I found out is when you have families encouraging the patient to train, then they are more likely to quickly than the ones they come by themselves. They don't have family supporting them to walk or do in that.
Thanks, Peter. So what I heard there was when the family comes, you have the opportunity really to train the family as well. Is that correct?
Yes. So they have their family coming to support them. They wait for them to encourage them, then they are more likely to walk quickly.
Yep. And that all leads to better outcomes often. I have a question for the group, actually. When we had COVID very badly 2 years ago, the World Health Organization asked my university to do some research on people who use assistive products around the world and what a difference was COVID making. And we discovered that that assistive products maintenance and provision and supply was not part of the COVID emergency medical response. So we heard that people could not get more batteries for their hearing aids. We heard that people could not get their prosthetic limbs repaired. We heard that people could not little children who went to school and used assistive products at school. School was closed, they had no computers at home. So lots of problems. But one of the solutions did not come from the governments, but came from people and communities. And we particularly had an example in India where the suppliers of assistive products like sockets and prosthetic limbs, the supplier would put the things to be repaired in a rickshaw or a taxi to deliver to the person who was the amputee who lived a long way away. So it would be contactless delivery, no one touching each other. And then the supplier would ring the patient and explain, and have given the Allen key or the tools, explain how to repair the prosthetic limb. So we learnt that people who use assistive products, you often could become very skilled in this, but they needed the advice from the prosthetist or the technical team on the phone. I wonder if you have any examples like that for me, or what that makes us think about just looking at different ways to keep people going with their assistive products. Was that a good idea?
So I'll share a little bit from PNG. So during the pandemic, so we went into lockdowns, and like particularly for our patients or clients who needed NOPS services, like they couldn't come into the service center or to the clinic to, you know, get their limbs repaired, prosthetic limbs repaired, or wheelchairs repaired. Some needed new prosthetic limbs, and they lived in other provinces as well, and it just made it really difficult for them. And what we did with the support from Motivation Australia, we came up with the idea to stay in touch with our clients through WhatsApp.
Through WhatsApp.
Yeah, through WhatsApp, and stayed in touch with our clients, you know, talking to them, advising them, trying to give them hope to stay put, stay strong. It's going to be over soon, and that you can come
Working at the personal factors, Alma. Yep.
Yeah. And for our team, the clinical team, we did take some risk. We actually went into the clinic to sit down and try to come up with plans to try and help our clients. So every time a client called, we had this spreadsheet, and then had the client's name, you know, on the spreadsheet, so we could keep track of how many clients we were talking to them online. And then, Motivation, Daniel and the team, they were in touch with us online as well. And you know, it was a crazy time. People were scared.
Crazy.
I was scared also.
Yep.
But you know, technology allowed us to, you know, stay in touch and, you know, support each other, and then support our clients as well. And as a result, now we have, like, I think we have over 20 WhatsApp groups in PNG now for different provinces, right? And by gender as well, like for male and female as well. So we try and stay in touch, and we try and help our clients online. And I know that my colleagues in the clinic, the technicians and the clinicians, when we cannot go out and see our clients, we do little, you know, footages or videos of how to put back the brakes, or change your tire and stuff. So they just see the videos and they try and work on it. So COVID taught us some good things, some bad things, and as a result, like, you know, we're moving forward with what we've gained from that experience, and helping our clients.
That's a wonderful story, Alma. See, you have the spreadsheet, you have the data, you know who was in touch. And what you've done is changed you've worked at the environment level, and you have used the internet and telecommunications as a facilitator. And that makes me think, how do people afford a mobile phone and a plan? Because it is a health issue for your people. They need WhatsApp so they can access you.
Yeah. Like in the past, a mobile phone was like quite expensive in PNG, including internet data. But now it's like it's becoming cheaper. There's different plans to use. So yeah, a lot of our clients, they're on Facebook and on WhatsApp, and you know, they go into WhatsApp and try to talk to us, and then when we are busy, they go and find us on Facebook, or they phone, text, or call. But yeah, we always tell them, but we are busy, we won't respond quickly.
Maybe too much access, yes, or they can
Yeah.
talk to each other.
Yeah, so that's from PNG.
Thank you, Alma. That's
during COVID. Yeah.
And I can see in the chat box, John has said, in community, working with family members is sometimes difficult due to discrimination and isolation because they don't understand the ICF, or they perhaps don't understand the social determinants of health in the ICF. Better to do more consultation with family and community as a whole to work together, and that can work in Melita in the Solomon Isles. Yeah, and it's individual and community are so locked together, aren't they? I've learned a lot from working with practitioners like yourself, and yeah, it's important not just to see the individual. Alma, I might come back to you with that story. There's a conference coming up in Sydney called Disability Policy and the Internet. So I think that would be wonderful to tell the professors, look at this is leadership from Papua New Guinea. Anyway, Daniel, I'm just going to whip to our whoops.
Yeah, we just have I've got another comment from Elsie, because Elsie's microphone isn't working. So Elsie in the Solomon Islands, who similar to Knobs, during COVID, clients were provided treatment through telephone services, and the education of the family was also provided through telephone services.
Yep.
And just noting, similar to the situation in PNG, mobile phone is great, but it can be a challenge in the provinces with low network coverage.
Yes.
Yeah, and Elsie also noted another mode of supporting clients during COVID is through caregivers and family members, teaching family members to repair and do maintenance on their family members' mobility device. Thank you, Elsie.
I'm so pleased to hear this work going on. And if anybody says to you, oh, you should be just working with the client, no, you're strengthening personal factors and the environment. And this is a very, very key intervention. So I have just put up a review of expected outcomes. I think we have talked about some strategies, and I use the word strategy or intervention the same, the thing you do with people, and that might look a little bit different for different clients. We talked about different daily living problems like the gardening or washing, or doing the washing or washing yourselves. To me, we have talked a little bit about different contexts, Australia and the Pacific, and we've had some discussion. Is there anything else people would like to ask or say or tell me we have not done enough of? Otherwise, I just put up the last slide asking for any questions or feedback.
Yeah, hello.
Hello.
Good. Elwin from Solomon Islands. I think the biggest gap in terms of documentations and the data, which is very, very much important for policy decision making. So in terms of data collecting at the operational level, it's very important at this present time, especially when we talk about policy, resources, human resources. It plays a very important information for decision making and planning. So I think this is what we are trying to do in ensuring that we document all data that can be helpful to analyze, to provide information for the direction of the rehab services, both the rehab and the disability. In our aspect, we look after these two components. So I would like to stress that when you raise the infograph on the assistive device findings, I think most at the higher level, that's what they look at, rather than just merely saying that it's a need, but it has to have an evidence, so that they make decisions related to allocation services. So that's one of the things that I would like to stress, that is very important in terms of documented data and inputs that will make very impactful changes in terms of reforms within rehab and reforms within disability spheres.
I can't agree more, Elwyn. And maybe we can do a future session on how do we capture these that in the clinic that can be done, and in very busy practices, because it has been told to me before, if we do not measure it, it did not happen. And that's a very frightening thought, isn't it? Think of all your good practice, but if we have not measured it and written it down and published it, then people do not know that it happened.
I think there's been a lot of work been done, but it's not been captured in as data, and get them into proper analysis that can influence changes in the decisions. So I stress that it's very important that to recognize that this data is very important for information and change of policy.
Thanks, Elwyn. Completely agree.
Yeah, hello.
Hello.
Yeah, thank you. I'm John. I just want to share, as well as what Elwyn has mentioned here in Malaita. We've been working with motivation during some of our trainings to provide especially the basic wheelchair and the intermediate. We have been providing a lot of wheelchairs so far for children and basic, especially the basic and the intermediate. There are some feedback which is good outcome of what we are doing. There are some children which they are using their wheelchairs and attending schools here in Malaita province, which is we see as one of the good outcome from the mobility device that we are issuing to our clients here. But the actually problem, as you already mentioned in the presentation, is we are not putting in the let's say a story, which is to publish that we achieve. This is what we achieve with our work here, especially for the mobile device. One of our latest child, which is we work with her from the primary to secondary. Now she's in KG doing his Form 7 grade, which is we really appreciate, especially what motivation has done to us by providing training and then providing mobile device with our clients here in Malaita. I think that is what I want to tell. Thank you so much.
John, thank you. That's exactly very important to hear, the outcomes that were achieved, over time, And whether we tell these stories by case studies or by collecting data in other ways, and I'm sure Motivation have a lot of skills in this area.
Thank you, John. That's wonderful to hear. And if there are if there is impact stories or certain client stories that you think would be good to share with Motivation Australia, we'd love to share them to our members and supporters as well. But that's wonderful feedback. Thank you. If there are no more questions, I'd just like to thank Natasha for her session today. I thoroughly enjoyed it, and I hope that many of you did as well. And certainly Motivation Australia would love to have you back, Natasha, to deliver a future session. And I just would note with that, if there is any particular topic related to assistive technology, assistive products, or occupational therapy that you'd like to hear more from Natasha about, then yeah, just let us know, either email, contact me, or put it on the feedback forms, which I'll send out later today. And I have recorded this session, so this session will be available on YouTube, and I'll send everyone the link and you can share it with all of your colleagues. But thank you once again, Natasha.
Oh, lovely to chat to you. Really, really lovely to be with my Pacific colleagues this afternoon. Thank you, Motivation Australia, for the opportunity. Bye, everybody.
Thanks, everyone. Have a good
Thanks,
afternoon.
Natasha.
Thank you for attending.
Bye, Daniel.
See ya.
Bye, everyone. Okay.
Thank you. Bye.
Thank you, Daniel. All right.